So next is new chapter transplant surgery, and the first topic is access for dialysis. It's V1. A 67-year-old man with end-stage renal failure with eGFR 16 ml per minute is referred to the vascular access clinic for creation of hemodialysis. He remains pre-dialysis and is otherwise in reasonably good health. How would you proceed with your assessment? Obtain a full history. Ask for symptoms of heart failure, as arteriovenous fistula can increase the cardiac output. Check right and left hand dominance. The non-dominant hand is always the first choice for creation of AV fistula where possible. Perform clinical examination of full veins, arterial and cardiovascular examination, and then perform the arterial and venous duplex scan of the upper limbs for vein mapping. The vein mapping shows good quality signal in the radial, brachial, and ulnar arteries bilaterally. The cephalic vein is 1.9 meter at the wrist and forearm and 3.1 millimeter at elbow bilaterally. The basilic vein is 2.4 millimeter at the elbow and arm. Where would you create the AV fistula in this patient who is right hand dominant? So general principle of AV fistula is common as follows. Choose the non-dominant hand, use as distal side as possible, use the cephalic vein where possible because it is more superficial, and use the upper limb than the lower limb. However, several studies have shown that 2 to 2.5 millimeter is the threshold for creation of successful arteriovenous fistula, especially at the wrist. So radiocephalic fistula created with the vein less than 2 millimeter caliber have 16% 3-month primary patency as compared with 76% for those with more than 2 millimeter in diameter. Therefore, left brachiocephalic fistula would be ideal choice in this patient. What are the advantages and disadvantages of the elbow fistula as compared to the wrist? The advantages: there are higher flow rates and quicker maturation than with the wrist fistula. The cephalic vein is easier to cannulate for dialysis than the and disadvantage is less long-term patency. The shorter vein length for needling once dialysis commences can lead to more arm swelling. There's higher incidence of steal phenomenon when compared to the wrist fistula. There's a higher incidence of cephalic arch stenosis. A 70-year-old diabetic who had a left brachiocephalic fistula created 6 months ago is referred complaining of painful cold left hand which worsens while he is on dialysis. How would you manage this patient? So take full history and complete arterial assessment. A duplex scan is needed to assess arteries to rule out any proximal or distal arterial disease and assess fistula flow. Physiological steal. It's common in fistula. Symptoms occur on dialysis as venous return is lower, which leads to reduction in the cardiac output. This lowers the perfusion pressure in the fistula outflow artery and the collateral supplying the hand. And persistent symptoms, breast pain and ulceration can occur in pathological steals when there is either proximal or distal arterial disease. This requires further imaging with angiograms and revascularization of the hand. Revascularization can be achieved through a variety of methods: ligation of fistula, bending of fistula, or drill procedure. What are the risk factors for developing ischemic steal syndrome? End-stage renal failure with diabetes both significantly increase the risk of peripheral arterial disease. Age more than 60, women, multiple operation on safe limb, and use of PTFE grafts. Thank you.